Hello everyone. Postpartum hemorrhage is defined as estimated blood loss of equal to or more than 500 ml after vaginal delivery or equal to or more than 1000 ml after cesarean section. Another definition of postpartum hemorrhage is a reduction in the patient's hematocrit level of more than 10% compared with the prenatal value or blood loss causing hemodynamic instability of sufficient degree to require blood transfusion. There are many other definitions also, but all are almost similar. So, postpartum hemorrhage is the commonest cause of maternal mortality worldwide and in India too. Postpartum hemorrhage contributes to approximately 24% of maternal mortality worldwide, and in India, it varies from 35 to 56% in different places. It is the biggest and the fastest killer. When we look at the causes of postpartum hemorrhage, atoricity is the commonest cause, constituting to 70%, then trauma, lacerations, hematomas, rupture of the uterus, then tissue, that means retained tissue, and thrombin, that means coagulopathy. WHO recommends active management of third stage of labor, that means injection oxytocin to be given, 10 international unit, intravascular or intramuscular, and it is the recommended uterotonic for the prevention of postpartum hemorrhage for all type of births, vaginal or abdominal, as this reduces the risk of postpartum hemorrhage by at least approximately 50%, and it is to be given within 1 minute of delivery. Now, the learning objectives of a PPH drill are learning management of a case of postpartum hemorrhage, knowledge of the contents of the PPH toolkit, and awareness of the facility level preparedness of the PPH response team. Now, this is an obstetric emergency, and there should be a team leader for overall coordination who assigns specific work to the members of his or her team, and it is preferable to call each member by name. This is called closed loop communication. The concerned member will say and confirm that the assigned work is done. Team leader does overall coordination. Assistant assists in performing procedures advised by the team leader. Supplier supplies all medicines and instruments. Usually, the nurse supplies the medicines and instruments. Observer monitors vitals and documents in the chart. There should be a relative and a patient too. Now, at the end of the drill, we do debriefing where we went wrong and what is learned. So, this is the case scenario. This lady was 34-year-old, gravida 3, para 2, living 2. She had a history of previous 2 full-term normal deliveries and now 39 weeks pregnant. Her pulse on examination was 72 per minute, BP 122 by 80 millimeter of mercury. Hemoglobin level 11 gram percent. She delivered 15 minutes back and active management of third stage of labor was performed. She is now having significant bleeding per vagina. Pulse is 88 per minute and BP 118 by 76 millimeter of mercury.
Ma'am, the patient is bleeding. Please come first.
Yes, the patient is bleeding. अभी आपको नीचे से ज्यादा खून चला गया है. घबराइएगा मत, आराम से लेटे रहिए और गहरी गहरी सांसें लीजिए. Sister, Dr. Achal, please come fast. Sister, get the PPH toolkit. डॉक्टर आयुष्मा, यू विल टेक वाइटल्स ऑफ द पेशेंट. सिस्टर, आप पेशेंट को ड्रग्स और फ्लूइड्स लगाएंगे एज पर इंस्ट्रक्शन. डॉक्टर आचल, यू विल रिकॉर्ड ऑल द ड्रग्स एंड फ्लूइड्स बीइंग गिवन टू द पेशेंट एज पर इंस्ट्रक्शंस. While I start and continue to massage the uterus of the patient.
Ma'am, BP of patient is 110 by 70. Pulse rate is 104. SpO2 is 98% on room air.
सिस्टर अश्विनी, पेशेंट को 2 कैनुला लगा दीजिए ग्रे कलर के. डॉक्टर आयुष्मा, कलेक्ट सैंपल्स फॉर सीबीसी, ब्लड ग्रुप, क्रॉस मैच, LFT, KFT एंड कोagulation प्रोफाइल.
IV cannula fixed.
Samples taken.
सिस्टर अश्विनी, पेशेंट को फ्लूइड कनेक्ट कर दीजिए, RL फास्ट.
So you can see in this chart that orange is the base cannula, whose gauge is 14 and the flow rate is 250 ml per minute. However, if orange cannula is not available, you can use the gray one also, which has 16 gauge and the flow rate is 180 ml per minute. So now in this picture, you can see different types of cannula. This is the gray cannula, which has 16 gauge.
RL connected.
Ringer's lactate is the fluid of choice, and for 1 volume of blood, we have to give 3 volumes of crystalloids.
Sister Ashwini, start oxytocin to the patient. Put 40 units in 500 ml RL and give at the rate of 40 to 60 drops per minute.
So the measures for a minor PPH is make an intravenous access with 14 gauge or gray cannula and do urgent venipuncture for group N screen of blood, full blood count, coagulation screen, and fibrinogen if possible, and monitor the pulse, respiratory rate, and blood pressure every 15 minutes, and commence warmed crystalloid solution.
Injection oxytocin 40 international unit in 500 ml RL given. But ma'am, why are we giving extra oxytocin to the patient? We have already given IM oxytocin after delivery.
Yes, Dr. Ayushma, that was from active management of third stage of labor. When we are actually managing PPH, we can give extra 40 units through drip. Sister Ashwini, एक इंजेक्शन ट्रेनेक्सामिक एसिड लगा दीजिए 1 ग्राम IV.
FIGO recommends administration of tranexamic acid as soon as the diagnosis of postpartum hemorrhage is made, as long as this is within 3 hours postpartum. 1 gram of tranexamic acid intravenously over 10 minutes is to be given regardless of the cause of postpartum hemorrhage. If bleeding continues after 30 minutes or stops and restarts within 24 hours after the first dose, a second dose of 1 gram may be given. And this 1 gram is 10 ml of 100 milligram per ml solution. If we give it fast, then it may cause hypotension.
Injection tranexamic acid 1 gram intravenously slowly given.
सिस्टर अश्विनी, पेशेंट को सीधा कर दीजिए, ब्लैंकेट उड़ाइए. डॉक्टर आयुष्मा, स्टार्ट ऑक्सीजन टू द पेशेंट एट द रेट ऑफ 6 to 8 liters per minute.
आपको ऑक्सीजन लगा रहे हैं, इससे गहरी गहरी सांस लीजिए.
मुझे कैथेटर दे दीजिए.
Catheterization of the bladder is an integral part of the management of postpartum hemorrhage. First, it tells us about the hydration status of the patient, and at the same time, an emptied bladder assists in contraction of the uterus.
सिस्टर प्लेसेंटा चेक कर लीजिए फॉर कंप्लीटनेस.
Ma'am, the placenta is complete, no cotyledons missing.
डॉक्टर आयुष्मा, यू विल असिस्ट मी इन द एक्सप्लोरेशन ऑफ सर्विक्स एंड वजाइना. सिस्टर अश्विनी, ट्रे दे दीजिए. Cervix and vagina explored for tears, intact. The uterus of the patient is still flabby. Sister Ashwini, patient को एक इंजेक्शन अर्गोमेट्रिन लगा दीजिए 0.2 mg IV.
Ma'am, BP of patient is 110/70, pulse rate is 96 and SpO2 is 98% on oxygen.
Dr. Ayushma, check for the status of blood and inform the relatives.
आपके मरीज की डिलीवरी हो गई है, लेकिन मरीज को डिलीवरी के दौरान ज़्यादा खून बह गया है, जिसको अभी हम दवाइयों के द्वारा रोकने की कोशिश कर रहे हैं. यदि मरीज का ज़्यादा खून बह जाता है तो मरीज को खून भी चढ़ाना पड़ सकता है और ऑपरेशन थिएटर भी ले जाना पड़ सकता है, जिसके लिए आप अपने रिश्तेदार खून दान करने के लिए बुला लीजिए. इंजेक्शन अर्गोमेट्रिन 0.2 milligram intravenously given.
The uterus of the patient is still flabby. Sister Ashwini, give injection Karba to the patient 250 microgram IM.
आपको कमर पे एक सुई लगेगी, घबराइएगा मत. Injection Carbopros 0.25 milligram intramuscularly given. Blood of the patient has arrived. आप अपने पति का नाम बताइए. Blood transfusion started after checking for compatibility.
The uterus of the patient is still flabby. While I continue to massage the uterus of the patient, Sister Ashwini, please put 4 tablets of misoprostol under the tongue of the patient.
जीभ निकालिए बाहर. ये 4 गोलियां आपको जीभ के नीचे रखनी है. Tablet misoprostol 800 micrograms sublingually given.
So when we talk about the medical management of postpartum hemorrhage, we have many choices: oxytocin, ergometrine, prostaglandin, misoprostol. Oxytocin is the drug of choice for the management of postpartum hemorrhage, and we should not give more than 3 liters in fluid, and it should not be given as IV bolus. Ergometrine, the dose is 0.2 milligram intramuscular or intravenous, and we repeat it at every 15 minutes. The maximum doses allowed is 5, and it is contraindicated in high blood pressure, preeclampsia, heart disease, and retained placenta. And if the patient does not respond to 1 or 2 doses, then we may have to move up the next in protocol. The next is 15-methyl prostaglandin F2 alpha. The dose is 250 microgram to be given every 15 minutes, and the maximum number of doses is 8, and it is contraindicated in asthma, and we do not give it intravascular. But remember one thing, that if the patient is not responding in 1 to 2 doses, then we do not waste time in giving 8 doses, rather we move up the protocol to the next uterotonic. Misoprostol, the dose is 800 microgram sublingual. One can give 1000 microgram per rectal also, but sublingual is better. And tranexamic acid is not an uterotonic, but it should be given, as I have already mentioned. And it is contraindicated in active intravascular clotting and convulsions. There is no evidence about the safety and efficacy of an additional 800 microgram dose of misoprostol for the treatment of postpartum hemorrhage when given to women who have already received 600 microgram of prophylactic misoprostol orally.
Sister Ashwini, give extra 1 gram of IV tranexamic acid to the patient.
Additional dose of injection tranexamic acid 1 gram given.
The uterus of the patient is still flabby. She has lost approximately 1200 ml of blood. Sister Ashwini, prepare for insertion of Brachy balloon. Dr. Ayushma, you will assist me. The uterus of the patient is contracted. The bleeding has stopped. अभी आपको नीचे से खून जाना बंद हो गया है, लेकिन अभी आपको थोड़ी 2 घंटे यहीं रखेंगे और ऑब्जर्व करेंगे. जब सब सही होगा और ब्लीडिंग नहीं होगी तो आपको वार्ड में शिफ्ट करेंगे. आप घबराइएगा मत, आराम से लेटे रहिए. आपका बेबी नर्सरी चला गया है. मरीज की डिलीवरी के बाद खून जाना बंद हो गया है, और हमको वार्ड में शिफ्ट नहीं करेंगे, यहीं रखेंगे. 2 घंटा देखेंगे, जब सब कुछ ठीक होगा तो वार्ड में शिफ्ट करेंगे. 2 घंटे के बाद की स्थिति बाद में बताएंगे. So today we managed a case of massive PPH. Dr. Ayushma, what did you learn?
Ma'am, I learned that good preparation leads to good work, and also importance of PPH toolkit. It helps in managing PPH in time, where every second is important.
Here I would like to speak the course of famous obstetrician Ian Donald sir. He said, 1 minute has 60 seconds, and every second counts in the management of postpartum hemorrhage.
Dr. Anchal, how was your experience?
Ma'am, today only I learned that we should follow the bundle approach for PPH. We should immediately initiate the bundle approach within 2 hours of onset of PPH. And if the bleeding is not controlled with one modality, we should immediately switch to the other modality of treatment.
Dr. Ashwini, what did you say?
Ma'am, today I learned the importance of oxytocin, that it can be used in both prophylaxis as well as management of the postpartum hemorrhage, and it should be used as the first choice of the treatment of PPH if the cold chain is maintained.
So, a case of massive PPH requires a multidisciplinary approach where you involve a senior obstetrician, a senior anesthetist, ICU experts, and hematologists.
When a massive hemorrhage occurs, then the resuscitation, monitoring, investigation, and treatment occur simultaneously. And we call for help, call the senior nursing officer or midwife, obstetrician and anesthetist, alert hematologist, alert blood transfusion laboratory, alert consultant obstetrician on call. And regarding resuscitation, we start ABC, airway, breathing, circulation, oxygen mask, then fluid balance. We give 2 liters of isotonic crystalloids, and this can be followed by colloid, but it's better to avoid colloid. Then we give blood transfusion, the group specific, and if group specific is not available, then O negative. And other blood products like FFP, platelet can be given. And always remember to keep the patient warm. And for monitoring and investigation, we put 2 cannulas, take samples, do ECG, we have to put a Foley's catheter, pulse oximeter, hemoglobin testing, and considering the central lines and administration of blood and blood products, comments record chart, we can have a quantitative estimation of blood loss. And we have to rub up the uterine fundus, we have to empty the bladder. Oxytocin is to be given as first drug of choice, followed by ergometrine, carboprost as and when required. If the uterus is still not contracting, even after giving all types of uterotonics, then we take the patient to operation theater, examine under anesthesia, look for any clotting abnormality also that is to be corrected beforehand. And then the first mechanical method is intrauterine balloon tamponade. It is to be given only when the patient is vitally stable. And this can be followed by brace sutures if the tamponade fails. And for that, we have to open the abdomen. If the interventional radiology is facilities available that can be utilized. Otherwise, we have to do a stepwise uterine devascularization, bilateral internal iliac ligation. The decision for hysterectomy is to be taken sooner rather than later. Saving the uterus and not saving the mother is of no use. These patients usually require admission in ICU or SGU. I would also like to talk about the temporarizing methods when appropriate care is not available. These are by manual uterine compression, external aortic compression, and use of non-pneumatic anti-shock garment. The role of anesthetist is very important. The management of PPH requires a multidisciplinary approach. The anesthetist plays a crucial role in maintaining hemodynamic stability and, if necessary, in determining and administering the most appropriate method of anesthesia. So we have to involve anesthetists early in the management. Our team members are Dr. Richa Madan, who is an SR, is the team leader. Dr. Aishma Puri, third year PG student who played the role of attending doctor. Dr. Aswini Mishra, third year PG student who played the role of nurse. Dr. Achal, second year PG student observer. Dr. Sneha, first year PG student played the patient. And Dr. Mayank Patel, second year PG student who played the role of patient's relative. My special thanks to my colleague, Dr. Harvinder Kaur, specialist in our department, for assisting in script writing. I thank each and everyone for their contribution. So, if we summarize the management of postpartum hemorrhage, then we should remember this pin girl. At the head end, we check airway, check breathing, administer oxygen, give sublingual misoprostol, keep the patient flat, know times of relevant events, and reassure women. Then at arm end, pulse and BP is to be checked, IV access to be maintained, blood sample to be sent, start IV fluid resuscitation, and we have to give uterotonic drugs. And here, aortic compression can also be done through this site. Then at the perineal end, we call for an assistant, massage the uterus, coordinate with the helper at head and arm, catheterize bladder. If at only apply by manual compression, consider Foley's tamponade, review the causes of postpartum hemorrhage, the 4Ts, tone, trauma, tissue, and thrombin. It is important to record the staff in attendance and the time they arrived, the sequence of events, the administration of different pharmacological agents, the timing and sequence, the time of surgical intervention where relevant, the condition of the mother throughout the different steps, and the timing of the fluid and blood products given. So, as I was telling, this is the obstetric hemorrhage chart. I adapted it from RCOG guideline 2016 and have customized according to my hospital requirements. You see here, we mention here team member when the on-call obstetric SR was called, when the consultant was called, when the anesthesia SR was called, when the anesthesia consultant was called, when we alerted the blood transfusion lab, called senior nursing officer, nursing orderly, all these to be mentioned. Then we have to maintain the pulse BP chart. Then we have to maintain the pulse BP chart. And when full blood count was sent, cross matching done, coagulation screen done, whether the placenta delivered or not, and type of fluids, volume, and time. And then when oxytocin was given, when ergometrin given, their dose, time, different doses of carboprost, etc. So this is the PPH bundle in pictorial form. We call for help, uterine massage, IV fluids, uterotonics, and examic acid, the first response bundle. Supportive measures are 3 tiers: empty bladder, empty uterus. Refractory PPH interventions are compression, uterine balloon, anti-shock garment, and supportive measures are transfusion, referral, and surgery. Remember remember that all modalities of PPH bundle must be used and utilized within 2 hours of the onset of postpartum hemorrhage if PPH is not controlled at any one point. One can put and display a PPH treatment wall chart in their living room, and it is very, very helpful in the time of need. And we should utilize SABAR criteria when necessary. It is a handover tool. SABAR is used to communicate needed information about the patient whenever a new clinician is assisting with or assuming her care. Here, an example of an SABAR when the obstetric emergency response team arrives to manage a postpartum hemorrhage. I am giving an example of the SABAR communication in this case. So, as per situation, the patient had a normal spontaneous delivery 15 minutes ago, but as soon as the placenta was delivered, she began pouring blood. B for background, like this is her third baby. She received 10 units of oxytocin within a minute of delivery, and the estimated blood loss so far is about 500 cc. I have already checked and I see no tears. A means assessment. It appears that she may have bleeding due to atony and is still bleeding, bristly, with a soft uterine fundus. R for recommendation. I am placing 2 IV channels now and will hang oxytocin. We need to address her PPH immediately. The team at this point can assume their roles in the emergency response team. So, say mothers stop postpartum hemorrhage.